panel is Healthcare 2025, a global perspective. And I want to introduce the moderator, Reenita Das. She's a futurist and a partner with Frost and Sullivan. You all might have heard of Frost and Sullivan. They do a lot of management consulting and a lot of the reports that we read, about healthcare. So take it away, Reenita.
Thank you, May. Good afternoon, everyone. It's a wonderful pleasure to be here. I'm glad to see some women in the room because I speak all over the world, and women in healthcare are less than 20%. So I'm glad that we do have some women today attending this session. I'm really passionate about increasing the number of women in the upper levels. So that's great. So today I'm going to talk about where the future of healthcare is going, and more from a global perspective. Talking a little bit about myself, I've been in this industry for more than 20 years, 2 decades, and the amount of innovation and change that I've seen in the last year or so has been tremendous compared to the last 19 years. But what is really sad is I love my job. That's the great part of it. But in the next 10 years, my job is going to become redundant. And have any of you thought really about how many of us will not have jobs in the future because they're going to be taken over by machines, by robots, by data, by analytics, by artificial intelligence. And we will have to constantly try to reinvent ourselves. And that is why it's so important to think about the future and prepare for the future so that you can reinvent yourself. So just talking about a little bit about where healthcare is going. A lot of the work that I do is really helping companies prepare for that future, identify growth opportunities, look at disruption, and learn from other industries. I mean, when I look at the financial services industry in the year 2000, it really reminds me a lot about what the healthcare industry is today. For example, in the year 2000, you had to go to a bank to get money. You had to wait in line for probably an hour to see someone who physically transacted the money in notes to you, and that was banking at that point of time. And the financial services sector had a tremendous disruption thereafter. And today, the relationship that we have with our bank will be similar to the relationship that we have with our healthcare, with our health in the future. So we can go up to a teller machine when we want 24/7 and take out money at whatever point we want. We ask to engage with our financial services institution at the time that we want. So we determine it. And I believe we're moving to a model of healthcare where we are going to move to a continuous anytime model. So our model at Frost & Sullivan, the kind of work we do is to help companies prepare for this change. And I'll quickly go through what are the 9 things that really are the holy grail of where healthcare is going to go to across the world. So obviously, we are moving away from an episodic kind of way of treating someone, seeing someone, they come into the radar, we treat them, we give them something, and they get out of the radar, and we forget about them. And we are moving to a continuous model where care is anytime, any place, anywhere. And any place is really what we're really talking about, similar to the banking system. We're also looking at a model where the right product is delivered to the right person at the right time through the right channel. Right now, we are not seeing that. We're also looking at a model where we're talking about reduction in errors. Today, 40% of costs are because of wrong diagnosis, wrong tests being done, misdiagnosis of those tests and diseases that leads to tremendous amount of cost being escalated. And last of all, the biggest change that we see happening in healthcare today, and this is worldwide, it's not just limited to the United States, is really the whole consumer revolution. Consumers are far more involved in their health today than they've ever been. There are almost 1 million groups on Google that are tracking diseases where people are participating on online Facebook groups discussing various symptoms and diseases, and they know these diseases better than any doctor would know the diseases because they are living with it and they're discussing with other patients. And this is creating a tremendous tsunami of change in the healthcare space. So in the next, this is a very interesting slide that we took quite a lot of time to develop in our firm, in our practice. So what we did is we looked at three sets of data over 3 periods of time, 2007, 2012, and 2025. And what we found was we looked at the percentage of money that is spent across the world in these areas. And we looked at 4 areas: how much money was spent globally on prevention, how much money was spent on diagnosis, monitoring, and treatment being all the drugs and devices. And what we are seeing in 2012 was that approximately 54% of revenues was spent on treatment. So it's a large percentage of money that is going into treatment, whereas diagnosis and monitoring is still very less. But in the future, we see this number going down, and we see the number in the last section in 2025. You can see that monitoring goes up by 16%, diagnosis goes up by 21% of revenues, and treatment is actually coming down by 51%. So if you are a pharmaceutical or just a pure play med tech company just producing products, you would really need to think of what your growth strategy will be in the future, because with this decline that we are seeing, people really have to think of building other solutions just beyond the product. And this is one of the biggest challenges today facing the industry. How do I move beyond the product? How do I move to business model transformation? And our panel will address some of that as we move forward. So what are the 3 big challenges today that are taking place in the world? Obviously, the first big one is aging population, and I'll share some numbers with you. The big regions that are facing this is Asia Pacific. We have a lot of EMEA, the European, the Middle East, the African regions, Australia, UK, and France. The second biggest challenge we see is obviously increasing population, and that we see largely in India and Southeast Asia. And then the demand for healthcare services. And when I mean healthcare services, I'm not talking about hospital services. I'm talking of services outside the hospital, which is the whole community-based service structure, the whole retail-based service structure that healthcare is evolving to, and that I see largely in the United States that we need to build, and build a care continuum as well in that service structure. This is some statistics that I thought I would talk about of where the numbers are actually going. So while we are going to see a decline in terms of the younger population, with obviously the way we've seen the birth rates declining in countries like Japan and in Singapore, we're also going to see a major problem in terms of the elderly. And by 2050, we're really seeing about 25% of the world being over 65 years of age. And that is a huge burden for states to have. For example, I work a lot in Japan, and right now they have a burden of around 25%. So they're going to get to almost 50% by 2050, which is huge, where half the population is not able to contribute to the economy. We're also looking at a growth of population going on to 8 billion people by 2025, which makes the way we are working today completely unsustainable. In terms of how much we spend on healthcare, I'd like to actually discuss something with regard to the US. Everybody knows that 17% of the US GDP is spent on healthcare, and as we keep going forward, we're going to spend about 25% of GDP if we continue to spend. But what is very interesting is I looked at some stats of what is happening in an equivalent industry in terms of the cost of products in that industry, and I took the automotive industry. So in 1960, the average price of a car in the United States was $2,600. And if I take the same percentage increase that healthcare has had from 1960 to today, the average price of a car would be $180,000. So if you just simply think about that, why is it different? Healthcare is no different than any other service industry in the world, but it's the only industry, service industry, where you buy a product and you don't know the outcome. And I think that is what has got to change with the way we are operating. So this slide talks a little bit about where the spend increase in growth is going to be in terms of GDP over the next 5 years. Obviously, Africa is leading the way. There's huge amounts of spending going on in Africa for investment, led by Asia Pacific, and third of all, it's North America. That's going to continue to spend. In terms of diseases, so there's not much difference between the 2015 rank and the 2025 rank in terms of the disease burden globally in the world. So we still see the top 2 categories being ischemic heart disease and stroke as the number 1 and number 2 ranked categories in the world. The change is obviously going to be in terms of COPD, which is going to take over by 2025. And in emerging markets, this is a very, very big challenge because we are not even there in terms of diagnosis. And diabetes is going to take the 5th place, which is a change from today. So we're going to see it move from 6th place to 8th place to 5th place. So these are some changes in terms of where diseases are going to go in the next 10 years. And this is important to think about as you build products and solutions for your clients and your customer base, to think about 10 years ahead, because it does take 3 to 5 years to get into many of the emerging markets. These are the stories we'll hear today. And then by that point of time, that the numbers you're going to look at may not be relevant anymore. The other interesting factor that we have seen is that a lot of the emerging market countries was based on infectious diseases. And we're going to see the change happen in the next 10 years, where the cause of death is going to move from communicable diseases to non-communicable diseases. So that is something else to think about, where the burden will be in the future. I wanted to share a study that we did, which was actually sponsored by Philips. It's a public study where we studied almost 25 countries in the world. We talked to physicians and we talked to patients, and there was almost 20,000, a sample of almost 20,000 across the world. And this was a question that we asked both groups. Can patients manage their health? So we asked patients, can you manage your health? And we asked doctors and physicians, can patients manage their health? And what is very interesting is we have the numbers by the 2 columns, and the ones in red show where the top 5 countries are, where there's a significant disproportion of where patients and physicians do not agree. So for example, in the US, 81% of patients believed that they could manage their own health, whereas doctors, 41% of doctors said they believed that they could. So there's a huge discrepancy. The other country was UK, Sweden, France, and Brazil. The bottom 3 countries where physicians and patients kind of more or less came to the same agreement was UAE, Japan, and Singapore. So this is something to think about. We were doing a study to look at the effect of connectedness and what people thought about a connected structure in each of these countries. So we talked to 2 large stakeholders on this. So the next slide talks about where the regions actually fare. And the question here was that, do you believe that your healthcare system is connected and integrated? And I haven't broken up the numbers by physicians and patients here. I have the total numbers. But it's very interesting to see that the countries that thought that they were highly connected are UAE, Singapore, Australia are the top 3. And then we have the United States, Netherlands, Sweden, and Japan. So these are some interesting statistics to actually think about, where there is a huge discrepancy about what consumers want and what physicians want. And obviously, the global barriers to some of the challenges for this overall is regulation, privacy, security, and all of the middlemen structure that currently operates in healthcare. So with this, I'd like to have our panel. We have a diverse set of people in this group today. Some come from science, some come from law and strategy. We have an entrepreneur who's actually selling products commercially in emerging markets. So each come from a different area, and we're going to have them contribute. So if you want to start, Jeff, by just giving a quick 2-minute introduction.
Sure. Thank you, Reenita, and welcome, everyone. My name is Jeffrey Coopersmith. I'm the principal at Coopersmith Law and Strategy. We did a needs assessment and concluded that the market really needed another law firm. Actually, actually, it turns out that what was needed was a firm that could help navigate the many subcultures in domestic and global health. And so we serve as the trusted consigliere to healthcare organizations, to corporations, and to NGOs. It also turns out that global health may be the most complex sector of all because of all the players, the roles for the multilaterals, for the corporate and commercial enterprises, for governments, for NGOs, and of course, for the sick and the vulnerable who are most affected and unfortunately have the least amount of influence. So we see that the challenges that we face for access and affordability and outcomes are really a product of systems issues, especially the financing models. So while we should continue to talk, I think, about the interoperability of technology, I'd like to see us also talk about the interoperability of technology with business and the interoperability of technology with policy and the interoperability of technology with finance. I think that once we start having those conversations, I can assure you that the decisions are being made, and the decisions are being made by those funders. Those are in many ways your customers, and they have been in those meetings. They are low information decision makers. They are not getting a lot of input and guidance from tech when they make these decisions, so we hope to help change that.
All right, my name is Usha Parinigam. I am currently in this role working as the head of data science with Global Emergency Care. So I come from a background of engineering and statistics, and then I went into medical school. I work as an ER doctor, and after that, I went to the Harvard Humanitarian Initiative, which is a group out in Boston that focuses on the academia of delivering good humanitarian aid. And so I did a bit of research and academic work there. I worked in a refugee camp in South Sudan, and then the war started and I had to be evacuated. So then I went to Pakistan and I worked on mass casualty response, and then the airport got bombed and I had to be evacuated again. So I moved slightly away from humanitarian aid more into development. In my current role with Global Emergency Care, I do a lot of data analysis and help them inform their programs. So Global Emergency Care is a NGO based in Uganda that trains nurses in an advanced degree so they can eventually run emergency departments by themselves. And I perform a lot of the data analysis behind that. I'm really passionate about the intersection in healthcare and technology, both locally and globally. And I think there's a lot of emerging roles that are playing a part of our digital health ecosystem that we could really benefit from globally, but we don't necessarily have the technical prowess. And I really believe there are people in this room who could help us out. So I look forward to talking more about that.
Shalabh.
Good afternoon. My name is Shalabh Gupta. I'm founder and CEO of a biotechnology company based here in California called Globavir Biosciences. By way of background, I'm a physician, did medical training, practiced medicine for a decade. I also have a finance degree. But more importantly, what I do currently, over the last 15 years, I've had the opportunity to play different roles in biotech industry. I started my career first working for a biotech company that was taking their drug to the FDA. This was the first conversation we had with FDA around 13 years ago. 2 years ago, the company got acquired by Alexion for $9 billion. So I got to see the products, the company, and the management when they were at the very ground level. Went to work with a venture capital fund, investing in biotech and medical device companies, Series A, early on Series A investments. And then went to work on Wall Street, working as a stock analyst, covering biotech stocks and then covering pharma stocks. I covered 6 of the largest US pharma companies and worked for UBS and moved to California, joined Genentech in corporate strategy. I started this company 7 years ago. And what I think I would like to talk about that even though you can categorize the word into 2 buckets, developed world and developing world, there are certain healthcare problems that are universal. There are certain diseases that are prevalent everywhere. The question is not so much about dividing them into 2 different buckets, but trying to think about what is a business model, what is a product that you are trying to develop, and how you focus. if you are running a for-profit company and your products are trying to solve a problem, if you can price the product and find a way to create value, you will be rewarded. And the value-based pricing is not just in developing countries, it's right here in the United States. And you probably hear this in general media, New York Times, and needless to say, previous presidential election talked about it. But value-based pricing is an important part of it. I'm fortunate that we have multiple technologies licensed from Stanford, and two products that we are currently focused on, two disease areas that we are working on, is oncology and infectious disease. And I'll talk to you about both of these. In infectious disease, we have a diagnostic as well as therapeutics. Thank you.
Kevin.
Hi, folks. My name's Kevin Grimes. I'm on the faculty here at the university and at the medical school in chemical and systems biology. Trained as an internist, went to the business school after practicing and teaching for a while, worked in government for a year as a White House fellow, and then went on this grand trip through the biotech and medtech sectors before coming back to Stanford 10 years ago. Teach drug discovery and development, see patients a bit. My main job is running a program called Spark, and Spark is a program where we help our faculty, our postdoctoral fellows, and our graduate students take technologies that have been developed, invented here at the university that might be turned into drugs and diagnostics for unmet medical needs. And we work with them to de-risk the projects, move them forward, and make that happen with the hopes that we're going to either move them directly into patients in some cases or find industry partners such as Shalabh, who will do some more heavy lifting and investing to help us get these products to the patients. One thing that I'd like to talk about is sort of the dichotomy of where our projects come from as we address global health. About 20 to 25% of the projects that we take into Spark are related to unmet medical needs in the global health sector, mostly developing world when I say that. And they really come from two areas. One is sort of what you think is the traditional academic exercise, where we have great scientists who are doing basic research, and they find something, for example, a protein or a kinase in a cell that's essential for a virus life cycle. We come up with a way to block that, and eureka, hopefully we have a cure for a viral disease. Well, that's easy to do in academia and in government labs. They have BSL 3 or 4 capability sometimes, but then actually making that a reality can be quite a challenge. The other way that we address this is really going by addressing the unmet needs up front. We find students, postdoctoral fellows, faculty from universities, for example, Zimbabwe, where we've done a lot of work, and we really bring them in and do training here locally over a period of months and help them develop something for a particular disease area. Often it's been diagnostics that they can then take back and continue to work on and roll out clinically. Very different models. In the latter model, you really have a good sense of what the needs are because these are folks who have a burning passion to solve a problem that they're facing in society. And we try and send them back more enabled to actually make that happen. But even when we do that, they still face the challenges of lack of funding and lack of infrastructure, et cetera, which are problems that are probably bigger than we can solve at Spark.
Wonderful. It's really exciting and interesting. So I think the big issue today for global health is, I see it as two big things. One is patient access and two is who pays. I'd like to actually have the panelists address what has been their experience when they've been working on projects on the ground regarding this or any other specific challenge that you've come across that you want to talk about. Jeff, you want to start?
Sure. I think first, before we talk about challenges, I would love to celebrate successes. I don't think we tout that enough in global health. I was just in the grocery store and I saw a cereal that proclaimed new box. Not new product or it's better for you, just new box. I thought, we in global health ought to learn from that. I mean, after all, we have in the past 20 years reduced infant mortality and maternal mortality by nearly half. We've cut down malaria deaths by 60% and transmission by 37%. We have comparable results for HIV/AIDS, all within the past 20 years, and all as a result of collaboration among these very complex sectors. So we didn't. Now we have PEPFAR. Now we have Gavi. Now we have the Global Fund and President's Malaria Initiative. Those have all been done in this time frame, and it just demonstrates that despite the very ample grounds for cynicism, we also ought to recognize the progress that we've made. I think on the challenges, so one of them is, so what if we're successful? Then what happens to these kids and families now that they are living with some of these diseases? And I think one of the big challenges is what Reenita identified, which is the non-communicable diseases. The fact is we have an epidemic of obesity, and I recognize I'm contributing to the epidemic, but we're never going to have a pandemic of obesity because there's no risk of contagion, right? There is no threat to the national order or to the regional order or the global order. So as a result, there will never be the same kind of funding for non-communicable diseases as there is for infectious diseases. Currently, it's about under 2% of all global health, all DAH, development assistance for health. Under 2% is for non-communicable diseases. That's not going to grow nearly commensurate with the need. So one, there's just isn't going to have the international consensus because it's not an international threat. And the other thing is, there is no bed net for cardiovascular disease, and there won't be. And it takes these systems changes to make a real impact in the advanced economies, and certainly in the US. We have done a poor job aligning the delivery and the financing models. We don't do a good job on primary care and preventative care. We haven't answered how to do stroke and how to do diabetes management yet. No one comes to the US for its diabetes management, right? So I think you are going to see a very fragile health systems in emerging markets faced with very, very significant challenges over the years, and those represent opportunities for us in global health as well.
I just want to add one more thing that Jeff brought up. I'm doing a lot of research today on behavioral health in emerging market countries, and just to start off with, the average number of patients who are diagnosed with some form of mental or behavioral health issues to physician ratio is 1 in 100,000. So that is the level of care that you can even expect to even start thinking about. So I think that just starts off straight off to say that we don't have enough caregivers in the system who are trained to even treat some of these diseases that are going to come up even more and more and become pandemics in the next 10 years. So while we're talking about a lot of technology today, I really think that we need to take the discussion beyond technology to things beyond that Jeff brought up. Sorry to interject, Usha, but go ahead.
No, I absolutely agree. And I really appreciate you starting with the positives, because you're right, we don't talk about them a lot. And as you go through NCDs, I'm reminded at the specifically in South Asia, you'll find these cities that deal with so much heart disease that they have it down to a science, and they are very good at treating their emergent cardiological conditions very well. You'll find centers in Karachi that can treat a acute heart attack for $900 to $1,000 and have financing models, have them in and out, and give them their 1 year of medications and care. And so there are things that we as people in the developed country could really learn from. And I think that we should use that as an area that we can intersect with them and learn from each other. As far as future challenges, especially as somebody who comes from the NGOs, I always want to talk about, obviously, funding, but I think sometimes when we are in the Silicon Valley, we are focused in the few areas of fundings that we know a lot about, specifically venture capital, and then in the academia in grants. But I think a lot of the social entrepreneurship is actually where the most interesting things will be in the future. Because in reality, whenever you create an NGO that requires donations to be sustainable, at some place you are not sustainable. So we created, our NGO specifically creates a educational program, but our goal is to become government certified and then create a tuition system that pays for itself. And honestly, ideally, somebody's going to copy our model and either do it better or do it cheaper or take it to another country. And if your goal is actually impact, I think that's fine. I do think if you are not financially profitable, you do lose your ability to be sustainable. And I think sometimes in the NGO world, the idea of being profitable is not necessarily appreciated as much as it should. I think people are starting to realize that, and I think there's a lot of people coming from outside that are really pushing it, and hopefully that is change that we can bring into our system.
So I'll give you a different perspective, and I'll start a conversation with a slightly different question. So one of the questions that people always ask is that, why do you exist? I'm not going to talk about my personal existence, but I'll talk about my company's existence, because we are a for-profit organization. And in order for building a company, which I started 7 years ago, the question is why? Why do we do what we do? Three things we wanted to do. One was to be able to impact patient care. The second was to be able to work on the technologies that would otherwise not be able to be implemented or be touched on, and I can talk more about that as we go further. But there are a lot of great technologies that are sitting in academia, and it's not that there is any lack of scientific rigor there, but there is a desire that somebody, an entrepreneur or a startup company, that will go early and start leveraging that technology and take it to the commercial stage. And the third part is that, which I also want to bring it here, is that we are a for-profit company. I remember this way back almost 15 years ago, that in graduate school we were taught that even not-for-profits have a mission, which is if you don't make money, you can't survive. So no profit, no charity. This is Sister Charity's mission, which was very well publicized. So for the for-profit company, our company's goal is for investors to be able to make money. So if I can summarize three things I said, is that make an impact for patient care, be able to leverage technologies that would otherwise not be touched, and third is make money. So if I think about these three things, then what do we do? How we have translated over the last 7 years what we started off. I'll give you three specific examples for that. So you can take a look at what we do in general, but we are currently working on oncology and infectious disease. And each of our products, I want to give you specifics to tell you what was my learning point, and as we go further along the panel, we can talk more about it. So diseases are not happening just in the United States. Infectious diseases are not just happening in developing countries. How many of you remember 2014 CNN reports of Ebola? How many people were infected by Ebola? 3 US citizens were infected with Ebola. CNN had 24/7 uproar about Ebola. Zika. Last year, CDC had a warning in Miami that if there is a pregnant woman, they should not be traveling to Miami. This is mainland United States. When I talk to people about Puerto Rico, they say, well, that's not the United States. I understand, but Florida is United States, right? These are infectious diseases. These are not things that were homegrown here. This Zika has been around. But you see, global travel, immigration, transportation, these are things that are changing the geopolitical environment that has not been precedented before. So if you think infectious disease is only a problem in developing countries, you are shortchanging yourself. And I want to point out only one point. This is a longer conversation. I'm not talking about politics or policy issues, but think about it. There is Ebola crisis. United States government puts $1 billion, different efforts trying to find a cure for Ebola. 2014, 2015, Ebola suddenly disappeared. Not because suddenly 1 year, the entire world's population had figured out how to make Africa a better place for healthcare delivery, or physicians had a better access to healthcare solution. Just so happens that natural history of disease, Ebola disappeared. The federal funding that was sitting for Ebola is now being transferred into Zika. If you go back to 2010, and there is a YouTube video, you can look up the CDC, these outbreaks have been coming year after year. And every time you talk to big pharma companies, they say, we cannot be prepared with a reactive response. You respond to Zika, what happens next? So there is that part that you have to think about, that infectious disease is not just a developing country problem. When it happens here, it is very real. 3 patients get infected. Everybody traveling on airplane is worried about, oh, you're traveling. You're going to get an Ebola infection. Chances of you crossing a road and getting hit by a motor vehicle accident is a lot higher than you ever getting Ebola. And that has not changed. So that's point number one I wanted to make, to consciousness, how we react. And this is not just about the US. Every society is mostly reactive. That's a human nature. So why I point this out to you. So when we started working, and Kevin talked about this great science, and I am fascinated and in deep admiration for the scientists whom I work with. we would never exist as a company, as whatever I do, without my scientists, the people who have helped build the technology, because they are very passionate about what they do. We are currently working on a dengue diagnostic, and I cannot make a company of 10 people, regardless of how much funding we cannot go and sell our diagnostic tests globally. So we realized at some point that what we can do best is to translate. Can we produce that test that was developed at Stanford with federal funding, government money, your taxpayers' money? This is the mandate the government has, that these technologies need to be translated into real product. It's not a wishful thinking. Just if you know that, if you want to look up, there is an act called Bayh-Dole Act. That means that the government funding should be translated into for-profit products if they can. So we took one of the diagnostic tests, we developed it, we got it approved in Europe, we got it approved in India right now. We're selling it in India on our own, but we partner with Bio-Rad, which is a global diagnostic company, and they're selling a diagnostic test. We don't think we can go do sales, marketing, regulatory approval in every part of the world. There's a second observation, and third one I'll tell you, on oncology. If you think about cancer, and I know I'm talking about it generally speaking, cancer doesn't happen to only people in the United States. Aging population in Asian countries, it's not just Japan, I'm talking about ex-Japan. So if you think about India, China, people are suffering from cancer. So oncology is a global problem. In fact, if you talk to people, and I was just talking to somebody again, lung cancer was not a major problem in China, but recently with the outbreak of pollution in Shanghai, the outbreak of lung cancer is increasing significantly. So we developed a technology for cancer treatment, and again, focusing on where we can take it, translate the technology, be able to partner. We were able to partner with a publicly traded oncology company, but we sold the technology rights to them so they can develop it further. So coming back to social entrepreneurship, making an impact looking in 2025, I think each one of us have a role to play. You have to identify what, and start with why. Why do you exist as an organization? What is your purpose? What pain point you're trying to solve? And if you can focus on those pain points, then I think you can make an impact. I don't have a solution for all the problems which I pointed out, but we are trying to focus on places where we can play a role.
Thanks, Shalabh. So the issue of paying is really challenging. But I think even before that is the issue of what we pay for. So we've talked about the leading killer in the world being cardiovascular disease and cancer #2. And we've sort of turned the corner with the smoking epidemic in the US and in Europe, but it's escalating like crazy in parts of the developing world. And this is a chip shot, right? Much cheaper than developing new treatments for lung cancer, to educate people and really work to try and turn this around on its heels right now. That probably is the best bang for the buck. A couple of other things. In terms of what really improves the health of a society, and this holds economic studies for the past 40 years, have shown what really determines health is level of education. And I think if we really want global health to be a reality, we need to follow through on the things that matter the most. This is education and standard of living and having some hope that your life has some purpose or meaning. So I'll get off my soapbox and turn into some other things. So let's think about products that we could pay for or not pay for. Some should be chip shots, right? A phone app. We have a professor here, David Stevenson, who's a neonatologist. He worked with David Benaran from a local company, and they have developed a very cheap and simple technology where you can measure bilirubin levels in a baby literally by measuring light reflection off the skin. No blood test, no nothing. You just get an instant readout. You can tell whether or not a neonate post-birth needs UV radiation or perhaps needs to be left out in the sun for just a little bit so they can get some UV radiation to treat their hyperbilirubinemia, prevent serious elevation of the bilirubin level and perhaps permanent brain damage. That should be a chip shot, should be very inexpensive. An app for a phone where you have a gadget, IR gadget to measure body temperature so you can tell whether your child has a fever or not. Should be a real chip shot, right? So there's some things that literally the consumers can pay for. Then you move into things that are more complex and expensive to develop. And to be honest, the for-profit sector can't solve these problems most of the time. But there are instances where I think they have. And one thing I want to point out is what Gilead has done with their HIV drugs, where, okay, they certainly charge a premium in the developed world. They have patented combination drugs. But they allow companies in India and other parts of the world to make these drugs and sell them for a very small percentage above cost, making these drugs available in the developing world for literally a fraction, probably less than 1% of what it costs here in the developed world. That's fantastic. That's a great economic solution for a problem and something we can be thinking about. Let's take something new that's going to be rolling out. Here at Stanford, we have a professor in ENT. His name is Tony Ricci. Tony's brilliant. Has great tissue models of cochlea, the hearing organ in the ear. One of the leading causes, in fact, I think the leading cause of deafness in children throughout the world is aminoglycoside antibiotics. Tony took this and by the way, aminoglycoside antibiotics and ampicillin, still the most commonly prescribed antibiotics in the neonatal intensive care unit in the United States throughout the developing world, and do cause deafness here as well. Tony decided to take this on. He figured out literally how these antibiotics are getting into the cochlear cells, identified the channel, figured out how to modify these antibiotics so they cannot get through the channel anymore. And, it's in late stage animal studies. We hope that this moves out. So again, think about that. This could be a dual market, right? You could develop this for use in the developing world and perhaps charge a premium, and then perhaps make it much less expensive in parts of the developing world. So we can come up with ways to do this. It's not easy all the time. But I think we have to think about where we're spending our money, think about how we're spending our money, and we can improve things over time.
Yeah, I think the points you bring up, Kevin, are excellent, because one of the things I think about every day is that in emerging markets, the penetration of the cell phone is the highest in the world. We're looking at almost 3 billion cell phones worldwide by the end of this year. So that could be one of the ways where access could be provided very simply and easily and close to home. Which brings the question up as to whether these countries will really leapfrog from where they are today to where they need to be compared to what we are going through here in the United States with a lot of different systems. For example, right now we are stuck with the whole issue of medical records. And the question that I think about all the time is, will there ever be a need for medical records in emerging markets where maybe the medical record will be on your phone eventually? So we will have leapfrogged a couple of generations of what we went through here to get there. There's some amazing pilots going on of drones in Uganda, in Bhutan, in Vietnam that are actually tracing where mosquitoes are going for malaria. So they can actually look at where the infestation is and wipe it out even before it hits the particular community. So where we are going with global health is probably a couple of generations ahead of the path we were taking in the United States and Europe. And I think that's one of my takeaways from where global health is going and one of the successes of this whole industry. I know we only have about 5 minutes, so I just want to have the panel just say their last concluding words in a couple of seconds, and then we'll take Q&A.
Sure. Thank you very much, Reenita, and thank you, everyone. I think that we talk a lot about technology as a frictionless engagement, and that's something to which we should aspire. But realistically, for the foreseeable future, perhaps we should be asking, how do we engage despite all the friction? And I think that the references here to like the Ebola epidemic and now malaria surveillance offer some good cautionary tales about how we can apply tech to global health. First, with Ebola, it was a convergence of low technology and luck that helped us. It's a very inefficient transmission. It's not a respiratory. If it were, we could not have kept up with the pace of the pandemic. And the way we did it in large part was using good old community health workers to identify symptoms and to do the hot spotting. So instead of using yesterday's tools for tomorrow's outbreaks, what we're learning is through these partnerships how to apply data in a pertinent, impactful way. There's a partnership between Tableau, the data visualization company, and Path in Zambia that I invite you all to look at, because what they've done is this hybrid of low and high tech. They're using low tech, the community, the trusted health workers, but they're using new diagnostic tools, and they're doing hot spotting, and they're taking these paper records, they're using their mobile phones, and they're transmitting the information. So now you have data visualization in the most sophisticated way of identifying where those outbreaks might be occurring, and who is responding to treatment, and how the different seasons affect it. So now there's a lot of data on the ground where it's needed most, and because it's cloud-based, it's very effective. It's also very effective because it is aligned, and alignment is the most important thing you can have in a partnership. It's fine to want a return. My party message is that there is $8.5 trillion in institutional funds and negative interest rate accounts. $8.5 trillion. So we in global health can lose money and give you impact. So there's lots of opportunity out there to unleash new tools in development finance for entrepreneurs and established companies in global health.
Great, thanks. So Reenita and I were talking about the leapfrogging technology earlier, and I really do believe in that. Mobile phones being the most obvious one, but drones and 3D printing, there's a lot of really interesting things going out there. The thing I would caution is just always be sure you understand how emerging technology plays in emerging markets. Drones are often associated with bombs in a lot of the different countries across the world. And so it might be medicines, but people aren't going to trust them. So it's just keep in mind your context when you come to that. The thing that I really agreed with and I wanted to focus in is data, because the Gates Foundation is actually the biggest driver of this. And starting in 2004, 2005, they really pushed NGOs and people to gather data and prove their interventions were working. And so we've actually gotten fairly good at gathering data. We are not good at actually implementing it, predicting it, and figuring out what we can use this for. There are some really interesting things going on. Mercy Corps is actually collecting a lot of data in Syria as they run their cross-border programs, and they are now getting to the point where they're predicting where the next attack will be, where the next needs for food and supplies will be. And it gets more politically dangerous when they do it, but it also is more interesting. So there is a lot of room there to grow, and I think there are people really doing interesting things there.
So I'll take some of the comments Kevin made. One of the things that I think is one of the most exciting times to be focused on working in global health, whether you're working for-profit or not-for-profit, is these models that now are coming up. Kevin talked about Gilead's model, differential pricing. And I think if you talk to somebody 10 years ago, a decade ago, talking about how you price a drug at X $1,000 in the United States and $1 in emerging markets, it will be something that most people will question you. But Gilead's example sets those tones that there are ways to be able to do good and still be able to generate revenue or still be able to do the right thing for your investors. That's point number one. Number two, I think we didn't get into too much into details about the pricing in emerging markets. And I think we as a company have always focused on that we do not want to price our products on the extreme ends of the market. Our goal is not to maximize profit, but to be able to have maximum impact. And to that end, what we are focusing on is what type of solution we can offer that will be quite unique that nobody else is able to offer. The work we are working on currently commercializing is a technology developed again at Stanford University. One of the projects that Kevin had helped me think about is a molecular diagnostic test that with one drop of blood you can diagnose a patient has a fever of unknown origin, and there are different agents for that. Dengue is one of them, malaria is another one, but there are a couple of other fever-generating pathogens that you cannot identify with any existing tests right now in the market. And we are thinking of pricing this test at the middle of the market such that it becomes one of the very unique solutions. And again, what Reenita was talking about, how you think about the new paradigm of medicine, the part that happens right now is that physicians in many of these countries are treating patients symptomatically because there's no real diagnostic tests that are being able to identify the real problem. So being able to diagnose a patient, we believe we can help by cutting down the cost of treatment. Patients who don't need the treatment because they don't have malaria, they don't have to get anti-malarials and so on and so forth. So I think my parting message will be, this is one of the most exciting times to be working in global healthcare. There are many, many solutions. You identify one unique one niche that you want to focus on, and there is that your way to make an impact.
Thanks, Shalabh. Wow, I get the last word. Never happens at home. I think there's one thing I'd like to close on, actually two things. One is I wouldn't underestimate what people of goodwill can accomplish. And one thing I will say about people who work in the global health space is there is no shortage of that. A lot of energy trying to move things forward, and I think it's really important to really think opportunistically about what can be done with the resources at hand quickly and make it happen. There are plenty of technologies out there that are really cheap and could really make a difference in a lot of people's lives, but they're still not readily available just for lack of funding of getting a 25-cent medication out to people once a year. That in and of itself says that as a world, we're not really too serious about this. So we really need to think about that. The last thing I want to say, though, however, is sort of gets back to a little bit about some of the viral epidemics that we've had. And reflecting back on the Ebola epidemic, which really ran about 10 months without getting a meaningful clinical trial established. There were people of goodwill at Gates, at Duke, at the World Health Organization who wanted to make these things happen. But there were a lot of barriers trying to move forward ethically, trying to get buy-in from people on the ground and government and so forth. And I think at the end of the day, we know this is going to happen again. We very much know this is going to happen again. We do have ways that we can track this with technologies, monitoring fevers, et cetera, et cetera. We should be ready to jump on this at the get-go. And what will it take? It will take for people who have the funds and the government to support public health enterprises in the countries that do not, and really get this stuff and teed up and ready to go. The next time there's an Ebola epidemic, I would hope that we could start out within weeks with the clinical trial that was arrived at a week before it ended, where there were three different treatments that were going to go into clinical trial to see which was going to be most effective at taking care of these patients. We need to be ready to move on these things quickly. Otherwise, tens of thousands of patients or worse are not going to make it. So I would encourage us to think about that. You know, a little investment in public health infrastructure, a little forethought and proactive thinking, what a difference that may be able to make.
Thank you, Kevin. Some wonderful stories here. I know we're running out of time and we're under a lot of pressure. Can we take questions?
Hi, my name is Tim Mackey. I'm an assistant professor in global health at UCSD. And I had a question about central financing mechanisms. So a lot of pooled procurement has been talked about in the context of doing things differently instead of differential pricing or compulsory licensing, those type of mechanisms, but things like the Global Fund. So I wanted to hear your comments about how important those central financing mechanisms are to scaling up solutions instead of just looking for country partners or individual bilateral vehicles. And then the second question I wanted to ask is about the WHO has an R&D blueprint that it's developing right now, and that's meant to provide some sort of safe gap or stop gap so that there is some pandemic preparedness for R&D and that there's a public good component to it as well. So I wanted to hear if you guys had any comments on that.
I'll take your first question. I think it's a very important part, and I agree with you. I think that's a permanent solution to some extent because I wouldn't go into specifics, and it probably is not in the purview of this panel here. But I think as we think about the treatment for diseases like dengue fever, these are the diseases that you would have somebody like Gates Foundation to be able to purchase the drug at a central level and then distribute in many different countries of developing world. There is no solution to that. At a for-profit company, even if you're a mid-sized company, it's just beyond our scope. So I just want to comment on that. So I agree with you. That is a better solution, and that's something most people are striving towards. And that's probably the most effective solution for that. I don't know, Kevin.
And there are some important innovative development financing tools that are being explored, but there are barriers too. The barrier is still that the multilaterals are still evaluated by how many loans they close, not what impact they have or what social, change they're achieving. So it's actually still not really possible to say, well, because we're going to support this part of R&D and we're going to bank this, we're going to have some long-term thinking. Long-term thinking is very hard for funders. It's very hard for policymakers. As a friend of mine who runs a global health program says, all of the uninteresting questions can be answered in the first few years. All of the uninteresting questions can be answered in the first. So we need 6 to 8 years to really be funded and pursue these things. Some of the tools, though, that they're using it's interesting that as there is progress in the global economy and countries go from low income to middle income, they actually lose the concessionary borrowing rates they earn, and then they don't fund health or education. So the World Bank is now trying to buy that delta down. They're also trying to de-risk, trying to deal with sovereign risk so that it's only project risk. And that is a very exciting, trying to do market, trying to work with commercial financial institutions to do market rate in long-term investment in healthcare infrastructure.
Any other questions?
I think we're out of time.
Okay.
Thank you very
Reenita.
much. Thank you so much for coming.